emotions are not a resting state network. Emotions are triggered. So you won't, if you look at resting state networks, emotions won't be activated. No, emotions are difficult to classify, but and there have been two major theories for emotions. One is the Cannon-Bart theory, which basically says if you see a stimulus, then what your brain will tell you, oh, this is dangerous, and that will change your heart rate and will create the autonomic nervous system changes. A second theory says the opposite, and that's the James Lange theory, which says you see a snake, your heart rate goes up, and because your heart rate goes up, your brain will interpret that as danger, and therefore it's the other way around. Which of the two is correct is a very long debate, but probably it's your brain. From a predictive point of view, if you see a snake, your brain predicts danger and therefore gets your body ready to run away rather than the opposite way. Furthermore, people who have a heart transplant can still perceive emotions through their so which you would not expect if this would be the correct way. So if you look at emotions, they're predominantly involving your amygdala. That's the central hub of your emotions, which in Loretta is not specified. It's not one unique Brodmann area, so you really have to visually look on if the anterior part of your hippocampus is activated in emotions. It also involves your ventral tegmental area and a large part of your prefrontal cortex. Whether an emotion is which emotion it is difficult to discern from what you see on imaging. Now you can conceive of emotions a little bit like that there is a kind of a primary emotion, and that depending on what other connections you have, you might get a different emergent property and therefore a different emotion. So and you also have to look at the fact that a lot of these areas are inverted U curves, which is important, and this has been shown by fMRI. For example, the salience part of emotions and the insula follow an inverted U curve for the phenomenology that is linked to it. So, for example, low activity will be perceived as unpleasant, high activity as pleasant, but it's the same area. And therefore, if you look at sadness and happiness, it's the same, virtually the same network, but that can be explained by the fact that if you have an inverted U curve, depending on the amount of activity, it will be this network will have as emergent property sadness, or depending on the activity, will have happiness as an emergent property. So conceptually, what is an emotion? It is a way of your brain to tell you that you have to process something with priority. Now, if you have to process it with priority, you have to get ready to process that, and then hypothetically, you could have a proto-emotion, which is arousal, which involves rostral, pregenual, subgenual part of the anterior cingulate, anterior insula, very similar as a network that is non-specific for emotion in general. And then you can have the separate specific emotions such as anger, fear, disgust, sadness, and happiness as basically modifications of these networks with different brain areas that are more attached to the concept of the benzene ring. So you have a proto-emotion, which I think is arousal. Then you can have a non-specific emotion and more specific emotions that you can just try to treat depending on which part of the connections that you can access. So if you then, for example, look at pleasure, to come back to the question, is it all salience? No, you can have different networks that are involved in generating something specific, and therefore those networks are of interest, but it's not just one network that is problematic. involved in a specific disease. It's often a combination. Memory is important, but as I said, memory problem can be secondarily to the fact that if you don't find it important, you won't store it. If you can't relate it to yourself, you won't store it. Memory has been subdivided in many different ways. Declarative memory, non-declarative memory, that will then be subdivided and still other kinds of memories. Trying to link that to pathology for myself. It's a very simple subdivision, cognitive memory, emotional memory, and then skills or habits, just to keep it simple. And memory is of course is important, but it has to be related to the self and has to be related to context. So what Merleau-Ponty in his book, The Phenomenology of Perception, has written is that any stimulus, any kind of percept has no meaning except in a certain context. It's the context that determines how it is. And he uses, this is in his book, basically these lines are exactly the same length, although that this one looks longer than that one, and that is because the context, these arrowheads are actually different. So it's the context that determines how you will perceive any stimulus, or these dots are the same in size, but the context here is different than that one, and therefore this one looks bigger than that one, even though they're exactly the same. And we all know that when we have a hot stimulus and we're in a hot room, we don't really like it. We prefer a cold stimulus, but a cold stimulus in a cold room we don't like. So it's the context that determines how you will perceive a certain stimulus. Now the context is processed in your brain in the posterior parahippocampal area. So in the posterior part, remember there was an anterior and posterior division, and the specifics are encoded in the hippocampus itself, and the context is encoded just actually surrounding the hippocampus. And the contextual network basically involves the posterior parahippocampus extending to the PCC and to the inferior parietal area. So basically, it's part of your default mode network. Your default mode network actually goes to the parahippocampus, and the parahippocampus then connects to your more anterior memory network. Whether you pull something from memory or push it in also goes via the posterior, and they call this the flip-flop mechanism, where the posterior cingulate actually pulls things from memory and puts it in memory. So memory always goes via the PCC, and then in Alzheimer, it's not surprising that if that is blocked because of the amyloid deposition, that you cannot access memory as easily, or you cannot store memory. And this is, for example, what you can derive from effective connectivity. Now, context consider of places, faces, time. There are certain scenes. So the parahippocampal area at large is involved in contextual memory, whereas skills and habits are more conditioned and predominantly involve either the caudate nucleus and the putamen, which you cannot pick up with EEG. So it's even though neurofeedback uses conditioning as a way of as a mechanism, you cannot really pick up the most important parts of conditioning, which is the nucleus accumbens and the putamen. Now the caudate nucleus, if you look at it, predominantly projects to the pre-general part of the anterior cingulate, which is involved in suppression of any stimulus. So whether it's pain, whether it's audition, whether it's vestibular, as we've seen, aggression is controlled by this top-down suppression of the amygdala, while the pre-general anterior cingulate has, depending on what it is connected to, has different functions. If it's connected to the periaqueductal gray and reticular nucleus of the thalamus, it suppresses irrelevant further stimuli. The connections, however, that go to the orbitofrontal cortex give rise to the feeling of pleasure. The putamen, on the other hand, connects predominantly to your salience network in contrast to the caudate.
There was a discussion about the default mode network and amyloid plaque and Alzheimer's, and we were looking at modules of the brain and so forth. But let's unpack that and talk a little bit about EEG, because neurofeedback deals with EEG, and QEEG, EEG stuff is what I like. So let's talk a little bit about that. Quite a while ago, Roy John did a very nice study on Alzheimer's patients, and basically he looked at the EEG and then waited 26 months and then looked to see whether the person was hospitalized, essentially in a care facility, or whether they were still independently with some help at home. And the EEG predicted quite accurately whether you were going to be institutionalized or simply need some help. And essentially what he looked at is the EEG alpha frequency, which the default mode network obviously has. It's related to alpha. It's got other frequencies, but if you just look at Roy's data, he looked at the alpha frequency. And if you look at alpha peak frequency, not the range of alpha, but the peak of alpha, when the alpha frequencies started to enter the theta frequency band, those individuals were going to be hospitalized 26 months, 2 years later, basically. If their alpha was still alpha, they were going to need some help because they were obviously demented. That's why they were being tested. But their progression wasn't the aggressive, rapid descent. So EEG alpha frequencies are also related to semantic and declarative memory, which is a piece of what's not working in Alzheimer's. They can't name people anymore. They can't remember factoids that they had embedded in their brain previously. And that's related to alpha frequency. This is work by Klemisch in Salzburg. They actually did a nice correlational study. People that had slow alpha versus fast alpha. And the slow alpha group had poor semantic and declarative memory performance. Fast alpha had superior semantic and declarative memory performance. Now, I emphasize performance because memory is not something you have, it's something you do. And you can improve your memory performance. If you actually had a failed memory, you couldn't improve it. But what they basically found is that the slow alpha group and the fast alpha, it's a very nice correlational study. But at that point, I invited them to come to the United States to a neurofeedback meeting. And they weren't into neurofeedback at the time. And Klemisch couldn't come, but he sent Doppelmayr, the next in line for the lab. And he came and we inoculated him with a virus of neurofeedback. And he went back and contaminated the lab. Because after he thought of, you can train the brain and you can shift the frequencies. Well, what about if we take some of these people who had poor memory performance with slow alpha and teach them to speed it up? Will that improve their memory? I mean, is this a correlation or is this causal? And what they found is that individual alpha frequency +1, speeding it up one silly little cycle per second, gave a dramatic improvement in semantic and declarative memory. So, people that have good memories have better 10, 11, 12, 13 content. People that have poor, again, semantic and declarative memory, not episodic or working memory, that's frontal and related to theta. But your alpha-related frequencies in memory, basically, if you have a 7, 8, 9 as your alpha, you're not going to be a great memory performer. If you speed up that alpha, the performance improves. Now, there are people that have worked with Alzheimer's cases. You can't cure Alzheimer's with neurofeedback, but you can improve their performance and sustain their ability to interact and behave like a regular person and recognize people and remember things by teaching them to speed up their alpha. Now, individuals that have poor memory performance, whether it's from one reason or another, teach them to speed up their background alpha. Now, ADD. You can have slow alpha and ADD. And if you have slow alpha, it's a totally different condition than having theta. If you have theta frontally, it can look like, the same frequency as slowed alpha, but theta in ADD is related to dopamine in the striatum, and you fix it with methylphenidate, which is a dopamine reuptake inhibitor, and you basically reinstitute the amount of dopamine and their performance enhances. But if they have slowed alpha, not theta, then all the dopamine in the world isn't going to fix that. That needs norepinephrine. These are the ones that respond to the amphetamines, Adderall, Vyvanse as brand names, but basically amphetamines. Or Strattera, which is a reuptake inhibitor for norepinephrine. Norepinephrine helps speed up the alpha, and a little bit of speed up in the alpha is, again, a major improvement in performance. And the ADD population have slow alpha. You can speed it up with neurofeedback, you can stimulate it with other neuromodulatory techniques, but you can also medicate. And the neurofeedback community isn't all really gung-ho on meds a lot of times, but I live on meds, so I don't mind that stuff at all. It keeps me alive day to day. So medications are important and not to be dismissed, but to be understood, basically. The other concept was obsessive compulsive disorder. And we're going to touch a little bit more on male-female differences when we come back. But it's important for OCD. Males and females have a different underlying pattern in OCD. But in general, obsessive compulsive behaviors are driven by the cingulate, the anterior aspect of the cingulate. When you're young, your cingulate is not developed frontally as well as it will be later. Your brain myelinates, and one of the last stages in your late teens, early 20s is you finally myelinate all the way forward. So in young kids, a lot of times you'll see activity in the back of the head that will be, as an adult, in the front of the head. As an example, occipital intermittent rhythmic delta activity, OIRDA. If you look at acronyms, it sounds like an odd acronym, but EEG folks are full of odd acronyms. So OIRDA is occipital intermittent rhythmic delta activity. If you have a deep near midline lesion as an infant, you see it in the back of the head as bursts of rhythmic delta in the back of the head. Same lesion, same location. In an adult, you see it as frontal intermittent rhythmic delta, FIRDA, F-I-R-D-A. So you can't judge these equivalent to cross maturation. You have to keep that in mind. But the anterior aspect of the cingulate is what basically gives you emotional and cognitive flexibility. And in OCD, you don't have that flexibility. You have a perseverative, stuck emotional or cognitive behavioral mechanism. Now, in EEG land, it's not just the anterior cingulate. When you have OCD, you think anterior midline is where you're going to see the problem. And that's where you'll see the problem if that's truly OCD. But it doesn't tell you what you'll see there. Leslie Pritchett, Roy John's wife, who still runs the brain research lab at NYU, did some very nice work. Look at the DSM. First of all, don't look at the DSM. It's fake. It's not really a real thing. It's a behavioral clustering, and it doesn't predict anything. So it's not valid. But it's an interesting book to flip through. And if you look at the DSM, it's gotten from a little DSM-1 to DSM-5 having to be on a thumb drive because you wouldn't want to carry the book. You'd end up with scoliosis from hauling it around. It's proliferated. Every category gets more categories, except OCD. OCD, there's one kind in the DSM. Well, neurometrics is NYU's game, and they thought, well, let's take a cluster analysis and ask the cluster analysis to find 2 clusters in the OCD population. And if you ask a cluster analysis to find 2, it will find 2. You can ask it to look for 3 or 4 or 5, it will find 3 or 4 or 5. If you ask it enough, it'll find 1 cluster for everybody in the damn room. But when you do cluster analysis, you want to add a cluster until it no longer makes any sense. And you've got as many clusters as you really need. And since there's only one kind of OCD, she said, well, let's find two. And sure enough, the cluster analysis found an alpha cluster and a slow cluster, a theta cluster, but it's really rhythmic slow activity. Now, partly they only found that because their database goes to 25 hertz and it stops. So, you know, faster content wouldn't be even seen, and they only asked for two clusters. So the cluster analysis found two clusters. You know, big deal, two clusters, whoopee-ding. You know, what is this meaningful? Are these clusters academic massaging of data into two piles which are meaningless? Or can you actually predict therapeutic outcome based on these clusters? Are they valid clustering? Well, they predicted medication effect. Now, most of the people here are fairly familiar with SSRIs, serotonin reuptake inhibitors. What's their effectiveness generally? Anybody got a percentage? What's their effectiveness?
39%. 39%.
39, 40, 45, some people will say. Well, in OCD, the anterior alpha cluster predicted 85% success. Lock and key, lock and key. This is the match. If you have anterior cingulate alpha, you've got a match for that SSRI. But the slow cluster, what's the percent responsiveness to the SSRI? 15. Which, you know, the placebo gives you 35 or so. So what the hell? 15, that's like no response, really. You're half the response of a placebo. So the alpha cluster responded and the slow cluster didn't. Now, we looked and we found a third one, not with cluster analysis, but just by looking at a whole pile of EEGs. And, you know, I've looked at a whole pile of them, so I thought back and I said, well, there's a beta cluster up there too. So let's look at it. And sure enough, the beta cluster exists at the anterior midline, and it predicts medication response to SSRI as a total failure. The theta cluster didn't respond to the SSRI, but they didn't go bonkers. They didn't have a negative side effect. It was just a waste of time and money. The beta cluster, they go bonkers. They will have anxiety, panic attack, meltdown right in front of you if you give them an SSRI or an SNRI, even worse. You know, if you see beta in the cortex, why would you give them norepinephrine? You know, a stimulating medication. So they respond negatively to SSRIs. And OCD, pretty much everybody's first guess on medication is going to be the largest cluster, the alpha cluster, and that's why they guess an SSRI, like Luvox, as a kind of a knee-jerk medication match to OCD. But if you see beta, there's 3 medication classes that will knock beta down. Antipsychotics, but if you have a discharge or an unstable, bursty EEG, it will make that worse. So you got to look at not just the beta, but also the stability of the EEG. And antipsychotics decrease the discharge threshold, and they will make the patient really, really a lot worse. You can give them clonidine and Tuniv 10x channel blockers to reduce beta, and they do a good job of that up to a point. Now, they're usually blood pressure medications used as a sympatholytic, something to drop down your sympathetic drive. And they work nicely up to a point. But if you keep moving if they work some and you need a little more effect and you move the dose up, basically you can drop the blood pressure out from underneath a normal person. So you can't just jack up the dose and have a better outcome. Anticonvulsants also work very nicely to drop beta spindling in the anterior cingulate. And we generally don't recommend like Keppra, which is a major anticonvulsant, which has major side effects. We recommend things like Neurontin, which it's an anticonvulsant, but 80% of all the Neurontin is produced for off-label non-epileptic applications as anxiolytics and sympatholytics to drop the arousal level and drop down beta. or Lyrica, which is a related medication. They're both anticonvulsants, and they're both adjunctive anticonvulsants. If you have a major seizure disorder and one anticonvulsant doesn't quite control it, they may add one of those on, but it's never really a primary anticonvulsant. So Lyrica and Neurontin can be used to drop beta content at the anterior cingulate, and they work. So you've got 3 medication classes to address it, but you can also address it with neurofeedback. What would you do? Well, suppress the alpha or the theta or the beta. OCD will probably be anterior cingulate. If you look and you find a failure problem up there, which one is it? And basically target that to get rid of it. And neurofeedback doesn't have any difficulty with this. OCD work with neurofeedback seems to work very nicely. Again, do we have good control studies in OCD? Hell no. We just don't have the funding.